This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand. Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest RANZCOG guidelines and RANZCOG research through in-depth conversations with leading experts in obstetrics and gynaecology across Australia and Aotearoa, New Zealand. I'm your host, Dr Kasia Siwicki. I'm an obstetrician and gynaecologist at Alice Springs Hospital in the Northern Territory. Today, we're diving into a sensitive and important topic in maternity care: substance use in pregnancy. I have three guests joining me today: Dr Anna Clare, Dr Dan Wilson, and Kerri Felemonow. I'll get you all to introduce yourselves. Let's start with you, Anna.
Hi, I'm Dr Anna Clare. I'm a specialist obstetrician and gynaecologist from Perth in Western Australia, and I was the chair of the Guideline Development Group that produced this document.
I'm Dr Dan Wilson. I'm an addiction medicine specialist and GP. I'm the clinical director for alcohol and other drug services in Central Australia.
I'm Kerri Felemonow, and I'm a social worker by trade and currently the manager of the Women's Alcohol and Drug Service at the Women's Hospital.
Anna, let's jump into the guideline. Why was this the right time to update the college's guideline on substance use in pregnancy?
Well, it was an opportunity to merge two outdated guidelines that were more than 5 years out of date, C-Obs 53 and 55, which covered separately substance use, alcohol and smoking. So bringing those together. There were also obviously new evidence in this area, new trends in substance use, new areas around vaping. It was really important, I think, to emphasise more non-stigmatising language within the document and encourage practitioners to do that. And also driven by need for equity for Aboriginal, Torres Strait Islander and Māori health priorities. And we wanted to make sure that we're improving access to consistent and safe care across both countries.
So, Anna, building off that, what would you say are the most significant changes in the guideline that you would like our listeners to be aware of?
So I think a big new trend since the last guideline is vaping, nicotine vaping, and so there's new content both on how to support women trying to aim to cease vaping, but also using vaping as a tool to reduce the impact of smoking harms. Universal screening is now clearly recommended early in pregnancy for all women, but there is flexibility for which screening tool to use. So clinicians should use a tool that they're comfortable with. There's an ongoing emphasis on culturally safe and non-judgmental care and stronger guidelines around person-centred language and respectful communication.
Thanks for touching on something really important there, which is language and how we talk about substance use as a health issue rather than as a value judgment. Kerri, I'm going to go to you. You work directly with women navigating substance use in pregnancy. How does non-stigmatising language look in practice, and does it make a difference to the way you work?
It makes a massive difference, actually, to how you work and how people engage with you. Language can be very loaded. It can be very sort of judgmental. So if you're using language like abuser or addict or even junkie, a lot of people will feel very further shamed, further marginalised if we're referring to substance use in that way. So you really want to be able to, engage people as early as possible into pregnancy care. People are coming to you for help. They, already know that they don't want to, that this is harmful and that they don't want to expose their babies to substances. So really you want to be able to work with them using respectful language and be compassionate to people's circumstances because, usually most people are in quite difficult circumstances if they are in that predicament where they're unable to cease their substance use when they find out that they're pregnant. So, yeah, we try very hard to use language that is respectful, that doesn't reduce people down to a single behaviour or action, and that takes into account their whole circumstance. I think, it enables people to talk to you about their substance use as well. If they're not feeling, they already feel shamed, but if they don't feel shamed or like you're judging them, then they're more willing to open up and disclose what's happening for them. It's a very vulnerable thing to discuss and a very personal thing to discuss.
Absolutely. Thanks, Kerri. We'll return to our conversation in a moment, but first, a quick message from RANZCOG.
Did you know RANZCOG has released the Australian Living Evidence Guideline Endometriosis, a fully updated clinical resource which will improve care for women and people living with endometriosis. Find out what's changed in diagnosis, treatment and management, including deep endometriosis is visible on ultrasound if you look for it. Physiotherapy and psychology treatments work. The guideline also includes a summary flowchart highlighting the care and management pathway of people with suspected or diagnosed endometriosis. A quick reference guide has been developed for GPs in primary care, and there are also new resources available for the public. The Living Evidence Guideline brings together the latest research with clinical expertise and lived experience to ensure care providers have access to reliable, up-to-date information. Explore the new resources on the RANZCOG website. Visit ranzcog.edu.au/endometriosis.
One of the key recommendations in the guideline is universal screening for substance use in pregnancy. Dan, how can clinicians weave universal screening for substance use into routine antenatal care without it feeling intrusive or judgmental?
I think genuine curiosity and aiming for an understanding of a woman's circumstances in pregnancy is the best starting place. There are well-recognised screening tools that can be used and should be incorporated into the approach that services delivering antenatal care to women should offer all participants, and these include tools like the Assist Light or the Audit C. The guidelines appropriately identify using at least 2 opportunities, but particularly, as Kerri said, early in pregnancy is a really important point to identify opportunities for promoting safety and wellbeing through the course of the pregnancy. I think beyond that, screening can shift into rapport development and building on a therapeutic partnership with a woman and her family and support people through pregnancy. And I would encourage clinicians to go beyond screening and really feel comfortable with asking about a person's circumstances, and that includes substance use. This is an approach that antenatal clinicians or clinicians who work in antenatal care are comfortable and familiar with, identifying what helps to keep a woman safe and well through pregnancy, and also balancing that against vulnerabilities and things that may negatively impact pregnancy. Substance use is another factor in that spectrum. So I think that screening can be a part of the universal approach for all pregnancy management, and beyond that, conversational understanding and contextualising care, individualising care, is an extension of universal screening.
And I'll just ask a very specific question, because very commonly we as obstetricians are used to screening for substances like tobacco and alcohol. They're the ones that we have available tools for. They're on the front of the antenatal pregnancy health records. Do you have any suggestions about how we screen for other substances, or should we then extend beyond that?
Some units often start and finish with asking questions about alcohol and tobacco use, and they're the most commonly encountered substance use or substances used during pregnancy. I think sort of a little bit like what Kerri was talking about earlier, helping women feel comfortable with sharing information and being able to receive appropriate support through pregnancy is really important. So if you ask about tobacco and alcohol, extending that into can I ask about experiences with other substances can be an easy starting point, and including that screening at other points in pregnancy is very worthwhile.
Kerri, I'll go to you next. The guideline highlights the importance of harm reduction and patient-centred care. Can you talk a little bit about when a pregnant woman is using substances, whether that's nicotine, alcohol, cannabis, or something else? What do safe, supportive care options look like in practice?
I think it's important to get a really good understanding of where people are at and what's happening for them in their sort of bio-psychosocial circumstances. A lot of the patients that we work with are homeless. They may experience mental health issues. They may be not treated or untreated with these conditions. Some people are living in contexts of family violence. We would be wanting to offer strategies and support to people that kind of meets their needs at that time. A lot of people will want to get people to stop using substances suddenly or reduce them very dramatically. And sometimes it's not safe with the substance, but it also may not be plausible or possible for that person at that particular point in time. So I think we have to take into consideration the whole person and think about what sort of strategies we're offering to people. So, for example, if someone's drinking alcohol and they're living with family violence and, alcohol's a coping strategy, we might be able to get people to reduce or drink something different. They may not feel that they can completely stop because they're still living with this stress and difficulty in their day-to-day. We might be able to ask that people eat some food before they consume some alcohol. Obviously, we would want people to stop, but after a period of time, we might be able to work with people to get the safety around them so that they can do that. And with other substances, for example, methamphetamine, if someone's using that, sometimes people are using that when they're street homeless. They need to stay awake, they need to stay alert. It's very hard to then just suddenly stop that if that's what is keeping you safe at night. So we might be offering strategies like making sure that people are using clean injecting equipment or rotating their injecting site, and then work on those other more stabilising issues so that people can then perhaps progress from that so that they can work further on their substance use with some of their basic needs also met.
We've talked about screening, we've talked about engaging women in care. Now I'd like to talk a little bit about what support and management can look like in practice. Dan, the guideline outlines both pharmacological and non-pharmacological supports, and that depends obviously on the substance. Can you talk us through what clinicians should be considering when planning safe medical care during pregnancy?
I think the guidelines do a really good job of giving practical approaches to pharmacological strategies in pregnancy. As Anna identified earlier, there are some really good guiding principles in there approaching nicotine use, for example. Using nicotine replacement therapy is very appropriate and is to be encouraged in pregnancy. Long-acting forms of nicotine replacement like patches provide continuous nicotine exposure at a lower level, and they can and should be, where needed, combined with short-acting immediate forms of nicotine replacement therapy like gums, lozenges or oral sprays. Vaping is a very relevant issue. Clinicians in antenatal care settings, GPs, addiction medicine specialists, this is something which is a relatively new topic for us to problem solve with clients that we work with. Vaping is something which has shifted in its evidence base recently. We do feel more confident encouraging vaping as a harm reduction strategy for women who are smoking tobacco products or using other tobacco products. And I think when viewed in that way, it is more unsafe to vape for someone who is not smoking. It can be a harm reduction strategy for someone who is smoking. I think that's a very clear guiding principle. And as Anna said, there might be situations where we work with women who are smoking in pregnancy and make suggestions towards use of vaporised nicotine as a harm reduction strategy to help make changes with tobacco smoking. Otherwise, I think it's worth talking about opioid pharmacotherapy or opioid replacement pharmacotherapy in pregnancy, which is not a controversial topic. It's an evidence-based, safe, effective strategy for women with high risk or harmful opioid use disorder, and medications like methadone and buprenorphine should be a routine part of antenatal care for women with opioid use disorder who would benefit from that form of treatment. Alongside pharmacological strategies, brief interventions, counselling, motivational interviewing, psychosocial supports, as Kerri was identifying, all of the strategies that can make a difference for the safety and well-being of women and families in a day-to-day sense. So supports around accommodation, finances, general health and well-being, psychological health, emotional health and well-being. These are all really important components of holistic care for women who use substances in pregnancy. And as Kerri also talked about earlier, identifying factors like homelessness, accommodation insecurity, experiences of family and domestic violence, alongside discussions around substance use, won't be relevant for every woman in that antenatal care setting, but it is very important to include that as part of a universal approach to help women achieve the best outcomes in pregnancy.
Alcohol is legal and socially accepted, but it still carries risks during pregnancy. Dan, how does the guideline recommend clinicians support women who are using alcohol in a way that's both safe and non-judgmental?
It's the most commonly used substance in Australia, and it's the most commonly used substance during pregnancy in Australia. So it's really important for clinicians to feel comfortable asking women about experiences of alcohol use, asking about patterns of alcohol use. Different patterns of alcohol use will carry different risks and will invite different responses and different supports. And I think it's very important for clinicians to be aware of the National Health and Medical Research Council guidelines, the NHMRC guidelines around safer alcohol use in pregnancy. For women in pregnancy, the evidence is very clear that there's no safe lower level of alcohol use. As Kerri said, sometimes that will challenge clinicians when we're working with a woman using a substance, inviting them, supporting them to make changes, but sitting comfortably with the idea that that might not be manageable or appropriate at that point in time. So including alcohol as part of a regular conversation and recognising that it is a very prevalent part of a lot of people's lives in Australia, and working out ways to incorporate harm reduction and safety and wellbeing into those conversations is really important.
And alcohol pharmacotherapies in pregnancy?
Yeah, it's there has been some recent evidence that does suggest the use of alcohol pharmacotherapies, and we're talking here about naltrexone and acamprosate as oral anti-craving medications that can help people either reduce or achieve abstinence from alcohol use. Recent evidence does suggest that when they are used in pregnancy, they can be safe and effective and appropriate, but there isn't a lot of numbers, there's not a lot of data to really recommend that as a routine part of the management for people with alcohol use disorders, but it may be appropriate in certain situations, and clinicians might benefit from being supported by a specialist service or an addiction medicine specialist opinion in that scenario.
Dan, cannabis is the most commonly used illicit substance in Australia and also in pregnancy. How does the guideline recommend clinicians support women using cannabis in a way that's safe and non-judgmental?
Again, starting with identification and understanding the role that cannabis has in a woman's life is a great starting point, and conversationally from there, working in partnership with the woman and their family, goals and recommendations and advice can be identified and provided. Even in addiction medicine settings, I do specifically ask about cannabis use because it's often not necessarily identified by people, by women, as a substance of concern. And if you ask simply about the use of illicit substances, cannabis might not be instinctively included. Kerri, would you agree with that?
Yeah, I think so. Yeah, it's so commonly used. I think people don't really think of it as problematic at times either. Yeah.
And particularly now with pharmaceutical or prescribed cannabinoid products, the normalisation in that sense of cannabis use, which can still include smoked or organic cannabis product, it's really important to specifically ask for it. And of course there are strategies that can help women make changes during pregnancy with cannabis use. Another tip that I'd give for clinicians in this space is to always ask about cannabis use and tobacco use mixed or together. Sometimes a woman might have a goal about reducing tobacco or cannabis individually, and recognising that someone mixes at the same time when they smoke, providing nicotine replacement for someone who's looking to cut down their cannabis use might be important.
For some women, opioid use is the main concern, and the guideline offers strong evidence-based guidance on how to manage this safely and compassionately. Dan, can you talk us through the role of medication-assisted treatment, like methadone or buprenorphine, and how these fit into best practice care?
Methadone and buprenorphine are gold standard for the management of opioid use disorder. Not everybody who uses opioids regularly will benefit from methadone or buprenorphine, but when someone has an identified opioid use disorder in pregnancy or during pregnancy, it is very appropriate to consider either continuing or initiating treatment with methadone or buprenorphine when there's an opioid use disorder that's identified. These are medications that are used to stabilise and prevent withdrawal, to manage and reduce cravings, and they also clearly provide health and psychosocial benefits for a woman and her family, and particularly in pregnancy. They are associated with better birth outcomes, the neonatal abstinence syndrome that needs to be considered, and often planning with clinicians, anaesthetists and others who might be involved around birthing is very important. Having a clear goal and an understanding of what the objectives of the treatment are during pregnancy can help a woman and her family feel more confident what they're doing is appropriate. And for Kerri, I think you can probably touch on the importance of case management or having a key contact person to navigate or help a woman navigate treating an opioid use disorder and receiving high quality antenatal care during pregnancy.
It's very important for people to have, I guess, in the Women's Alcohol and Drug Service, people have a midwife and a social worker allocated to them so that they are able to, navigate health kind of systems more effectively, and then other psychosocial systems more effectively. And the Women's Alcohol and Drug Service was actually originally set up to manage opiate use, really. It's something we see a lot less of now in the service. We certainly see a lot more cannabis use and methamphetamine use, or a combination of several other things. And more recently, we're seeing a lot more GHB as well. And, but what we do know is that opiate pharmacotherapy for opiate dependence has been very effective for many of our patients, and it has really enabled these families and women to stabilise in themselves. And we know that there has been, that it does help with better birth outcomes. We know that babies more likely to get to term birth. We also know that many of babies may not experience withdrawal if someone's been stable on their pharmacotherapy treatment for a period, a good period of time in the pregnancy. We do really encourage people, where possible, to be able to access and utilise methadone or buprenorphine in pregnancy.
And I think I'd just add to that for clinicians providing antenatal care, when they are working with someone who's on a methadone or a buprenorphine program, having a clear link between among the woman, the antenatal care provider and the opioid pharmacotherapy prescriber for clear communication and understanding of goals and objectives is really important.
Thanks, both of you, for really highlighting that important message, which is that the impact of substance use on safety and wellbeing depends on so many factors. There's structural, social, historical factors that influence how people access and engage with and relate to care providers. Anna, I wonder if you can comment on how the guideline responds to that sort of broader picture for people who have substance use concerns in their pregnancy, and particularly on its focus on equity for Aboriginal and Torres Strait Islander women in Australia and Māori women in Aotearoa, New Zealand.
I think it's really important to acknowledge the ongoing impacts of colonisation, racism and intergenerational trauma that affects these First Nations communities. There is a high rate of substance use in some communities, and that tends to be shaped by social and structural determinants of health The guideline really tries to emphasise the importance of culturally safe care models, so that might include yarning circles in Australia and Wananga in Aotearoa, New Zealand. It supports the use of the Māori Equity Toolkit and collaboration with cultural liaison staff in the hospital and community. And I think it really pushes for health service accountability for embedding equity both in health policy and also in our day-to-day clinical practice.
Dan, I wonder if you could talk a little bit about trauma-informed care, because this is obviously a big part of the picture, and Kerri, feel free to step in. Could you talk about how that connects with culturally safe practice?
Absolutely. Trauma-informed care is essential, and whether you're providing care in a substance use setting, in an antenatal care setting, recognising that clients, health service participants, women in pregnancy have a range of experiences through their life that impact the way they think and feel and respond, particularly in healthcare settings. To me, trauma-informed care is a way of shifting the focus from what's wrong with you to tell me about the experiences you've had and how that has impacted you. It shifts the focus in a substance use setting from tell me what you're doing that's wrong to tell me about your experiences with substances so that I can understand how that relates to your context, and I can provide strategies or advice or support with a focus on health, wellbeing, safety, and in pregnancy, positive pregnancy outcomes. So I think trauma-informed care in that sense really prioritises safety, choice, collaboration, autonomy in decision-making, information sharing, and it turns antenatal encounters into a two-way shared experiences where we're not telling people what to do or what decisions to make, but we're giving them a framework for understanding, and we're also looking to understand the person in their context and using that to inform our advice and supports to the woman and their family. This approach, I think, directly aligns with the new guideline, which calls for non-judgmental and culturally safe care. I think as a clinician, you can always reflect and learn from encounters, and it is absolutely fine to reflect on what's worked, what hasn't worked in our care for women and their families in pregnancy. And as clinicians, we should always be looking to improve our practice to be more inclusive and more responsive to the person in front of us.
Do you have anything to add, Kerri?
Trauma-informed care is certainly, it does no harm, and it certainly allows, if we assume that with most patients we're encountering, really we're just offering really great compassion and care towards them, and they are more likely to, or patients are more likely to engage with you if that's how we're approaching them and their situation.
Mm.
And I think for Indigenous, Torres Strait Islander and Māori communities, it's really important to recognise that the traumas and the experiences that can be defined as traumatic may not immediately be apparent to me as a clinician or to the health system on the whole. So as Kerri said, being non-assuming and non-judgmental and really being receptive to the experiences that people have had and are having through our care encounters is, that to me is trauma-informed care.
Kerri, you would see equity issues playing out in practice for the women that you work with. And working in a dedicated service obviously has its advantages because there's a safe space that is catering to that population very specifically. Could you give perhaps a little bit of insight into how hospital environments may not feel so safe or welcoming for some women, particularly those experiencing substance use?
Hospital environments can be or have had histories of being quite unsafe for many people, and especially our Aboriginal and Torres Strait Islander people. Stolen generations and hospitals were very closely sort of aligned, and I know the women's has a history there. So I think it's important to always remember that when we're working with particularly Aboriginal and Torres Strait Islander people. They may not be coming to their appointments because of the fear, because of the shame. It could be around substance use, but they are often afraid that, disclosing substance use issues to a health practitioner will lead to them having their baby removed from them. It's a fear based on some of that intergenerational experience, but it's still a very prevalent issue for many Aboriginal and Torres Strait Islander families today. So it is something that we need to be very mindful of as practitioners and look at ways that we can work closely with Aboriginal health services within the hospital or in the community to work better, particularly with these populations, and really work closely to make the experience of healthcare safer for them, and also ideally a positive one. We want people to feel that they can come back to a hospital, come back to a healthcare provider, especially when people are having babies. We want people to be able to engage down the track in care and to continue to want to engage with healthcare providers.
Not everyone, however, has specialist services in their area or on site, and especially those working in rural or remote areas. How can clinicians in those settings still implement the guidelines, recommendations and best practice in a safe and practical way?
From a structural or a health systems approach, making sure that universal screening is embedded in the antenatal practice is a really good starting point. Making sure that clinicians working in those areas are empowered to have skills like conversational approaches to substance use in pregnancy, feel confident to provide at least some initial advice, feel confident to provide some interventions like brief interventions, which might be a 5 to 10 minute, a short, brief, individualised set of information that can be structured toward that person in their circumstances. Brief intervention frameworks like flags, feedback, listen, advise, goals and strategies, or the 5 A's, asking, assessing, advising, assisting and arranging. They are good skills for clinicians working in less resource-intense settings to have and to continue to develop. Harm minimisation approach and really feeling confident to provide information or advice to a person that doesn't necessarily solve a problem or fix a problem, but can make a problem a little bit easier to manage, a little more stabilised, or at least an issue that is able to be discussed and talked about and evaluated over time. Being aware of what your resources are. If you don't have a specialist multidisciplinary service, being aware of what clinicians you can link in with at a local level, what clinicians are available further afield, and how you can be in touch with them either for advice, perhaps telehealth or online assessments are very available and accessible. Addiction medicine specialists love talking, and addiction medicine specialists love problem solving, and we love thinking through problems collaboratively. So I think if you can identify a service or a clinician that you are able to reach out to if there's not one in your local area, you'll always have a friend close by.
And Kerri, I think when we were preparing for this podcast, you talked about statewide services, or you and Dan talked about statewide services that are available for in Victoria or elsewhere. Could you maybe flag any of those that you're familiar with?
The Women's Alcohol and Drug Service offers a statewide secondary consultation service, so people can ring us and get advice in Victoria. There's also other services that exist that GPs, I think, can contact. The Drug and Alcohol Clinical Advisory Service, that's a service that provides advice for people, for medical practitioners 24 hours a day. I think there would be other services like that across the different states.
Yeah, I think most states and jurisdictions tend to have slightly different structures in terms of how specialist addiction medicine support is provided. And but as Kerri said, each state and territory does have its own 24/7 clinical advisory services. And for someone who's new to an area or unfamiliar, I'd really encourage them to explore what services are available.
So we've talked a lot today, and it's a message that is very clear that substance use in pregnancy doesn't happen in isolation. It's part of a more complex picture, and therefore it needs to be approached in a holistic way. Anna, what does the guideline say about the role of multidisciplinary teams? And I suppose from your perspective as an obstetrician, what is the role of a multidisciplinary team and an obstetrician in supporting a woman holistically through her antenatal course?
And as both Dan and Kerri have mentioned today, multidisciplinary care is a key theme in the guideline and in practical care for women who are using substances, and it's linked to better maternal and neonatal outcomes. Teams need to include maternity workers, so that would usually be GP obstetricians or obstetricians, midwives, neonatologists, anaesthetists, addiction medicine specialists, mental health teams, and social workers. As Kerri mentioned before, a caseworker or a key worker who helps coordinate care and becomes a point of contact for that woman is also really important to build a consistent, trusting relationship. The support has to go beyond the clinical. It's not just looking at their immediate, antenatal care, but also addressing wider issues around housing, legal issues, can give support to access financial services, trauma experiences in the past, and wider mental health alongside substance abuse. Antenatal care is a great time to build relationships. It's a real motivator for women, a catalyst for change for the positive, and these relationships can carry on through to the postnatal period, and the teams can help to build continuity and stability for those women. And the guideline recognises the importance of education, planning for postnatal care, and ensuring support for both the mother and the baby long term. I think the role of the obstetrician within this team is looking at sort of the baby's well-being through the pregnancy. So that is usually organising growth scans, ideally on a planned regular basis, but often opportunistically when women present to care. And I think it's really important to be just a little bit more flexible with women who are struggling to come in to be seen, in just providing the care at the time that's appropriate to them. And the other thing is appropriate timing of birth, which is usually involving the multidisciplinary team input and making sure that everyone's aware of the timing of birth, because that can become sort of a crisis point sometimes.
Particularly in the really critical postnatal period, which we know is a really vulnerable time for a lot of women because services have been delivered for a long time and they've had good contact with services, but postnatal period often feels a little bit like all of that extra support has sort of maybe fallen away. How do you find in practice that the relationships and wraparound care can be maintained once you've built it antenatally?
It is tricky, and I think there's been research around that sort of dropping away of supports soon after the baby's been born, or within 6 months of the baby's being born. We have developed an extension of the WADS program to really try and address some of these issues of support, and all babies that are born through the Women's Alcohol and Drug Service have access to a social worker and midwife postnatally, and they will do some assessment and follow-up, and when those babies come back for paediatric follow-up and care. That is a relatively new area for us to have this extension of care, but it is really important to, I think, have that continuity, because people do, over a period of time, develop trust in people. It's very hard for people to get about and retell their stories, meet new people, have to go through some of that fear and challenge of disclosing personal issues to yet another clinician. So trying to keep that, or having that sort of relationship and the continuity of that relationship but in the one service, can be highly beneficial for people. I do have to say another very important feature, I think, in Victoria, I'm sure it's in other states as well, are people like enhanced maternal child health nurses. Many of these people have very significant relationships with families and are a great support as well to families. So that is also a very useful resource for women and babies as they enter that postnatal period.
Pregnancy is a real time of change, and substance use does change during pregnancy. There is also, as Kerri said, a really recognisable return to substance use for some women after pregnancy. So establishing those relationships and creating those networks of support for women and families during pregnancy is so important to carry on beyond birth, to maintain change that has been achieved during pregnancy, and to maintain that advocacy, not just around substance use in pregnancy, but the advocacy for psychosocial and social and emotional well-being and safety.
Kerri, perhaps for spaces where there isn't that specialist wraparound care available postnatally, and as you said, that's a relatively new development even in your service. Once women leave a public hospital, they're not often going to have contact with an obstetrician for postnatal care. Can you perhaps highlight some other practitioners or services that public hospital obstetricians and junior doctors working on the wards can maybe try to flag for women as being spaces where they might be able to seek that ongoing support and care?
I certainly do think that through enhanced maternal child health nurses are a very great resource for people, and most babies are going to have, appointments or contact with, if not an enhanced maternal child health nurse, a maternal child health service. But I certainly think it's something that, perhaps GPs, will be able to support people with referrals to perhaps psychological help or to addiction medicine services if women need that a bit later on after they've had their babies. We certainly have some community services that we work very closely with in the postnatal period. But I think more importantly, being able to speak to women about going to their GP if they're struggling with things again, or to their local community health service, which will often be able to, if not offer a service that's for them and their baby, or they will possibly be able to link them in with some family services or some support services so that people still have access to that.
Yeah. And perhaps, Anna, from an obstetric point of view, a continuity of midwifery care services would be another space?
Yeah, continuity of midwifery care services that will provide ongoing support for several weeks afterwards are really important for this group. Yeah,
absolutely. Thank you all for your time. Before we wrap up, I'd really like to hear one key takeaway from each of you, something that you would like our listeners to carry into their own practice based on your thoughts and your experience. Anna?
I think it's really important to have practical advice. So I think the guideline gives really clear advice on how to have safe and respectful conversations with women. And just like a small shift in language or in your approach can make a big difference to patients.
The guideline isn't about turning an antenatal clinician into a substance use expert. Clinicians need to be curious, respectful and receptive, and use every opportunity to build rapport, work towards harm reduction and safety and wellbeing as the goal, be relevant, focus on the woman's priorities and what they feel is possible and achievable, and treat it as a two-way conversation. It's best when we're working with people, not for people or on people, to foster change.
I would say that pregnancy is a very important time, a major time for most women and families, and that you just never really know who is going to thrive if they have the right support and if they're able to engage well with those health professionals that they're working with. You really just don't know who is going to make significant changes. So don't make any assumptions when you meet people about what possibilities there are for them and their baby.
Thank you all, Anna, Dan and Kerri, for your insights and for your commitment to providing care for women and their babies who are experiencing substance use issues. To our listeners, we've linked the full RANZCOG guideline in the show notes, and it's essential reading, and I encourage you to delve into it. If you found today's episode helpful, please rate, review and subscribe. And why not share it with a colleague? It's a simple way to help others find Talking O&G. And don't forget to log this episode for CPD. You'll find a form linked in the episode show notes. We'll be back soon with more expert conversations shaping obstetrics and gynaecology across Australia and Aotearoa New Zealand. Until then, thanks for listening.